Okay, we're going to pick up for where we left off yesterday, which was number 13, and we're glad to have the Australians here to help us get this straight. High concentration nitrous oxide for procedural sedation in kids. They allow these, and this is a large study, 762 kids. You're not going to see a study like this ever in the United States. Royal Canadian Children's Hospital of Melbourne. They're looking at efficacy and safety. And basically, they'll allow these doctors to ratchet this stuff up to as high as 70%, which is still 30% oxygen. Last I heard, you just need 21%. But in any case, this looked at problems. This is about efficacy and safety, and basically they had 2 cases which had what they called severe adverse reactions. Now, this is out of 762, 2 severe cases. Which were they? One of them had chest pain. One of these kids had recurrent chest pain. We have no idea why. And the other one had persistent desaturation, even after the gas had been turned off for some reason. That was also very enigmatic. When they looked at nausea and vomiting, a small percentage. It was nausea 3% with, and it didn't seem to matter the amount of nitrous, 50 or 70%. The point of this paper is, why can't we in the United States use nitrous oxide? Just put this mask on the kid, gas them up, start the IV or whatever you're going to do, and we need our brothers and sisters from Australia to say, hey, yeah, we use it and we like it. Anytime you're ready, go ahead.
Well, we said in the U.S. No, do you use it on your patients?
Yeah, we use it and we like it. The trouble is it's on the staff.
Well, no, any of you Australians out there use this stuff? Come on, tell us how that you like it. Well, we do so many stupid things in the States. I mean, why would you be surprised? We need some endorsements, because what we would like to do is we'd like to get your enthusiasm conveyed to our colleagues here and say, go back to the hospital and say, hey, what's your story? If they can use it in the dentist's office, I want to use it in the emergency department. And I want to use 70%.
We have absolutely no rational approach to this at all. In my institution, there's absolutely no problem using drugs that paralyze you or make you stop breathing. But when the first time we wanted to use ketamine in our emergency department, there was the Spanish Inquisition. It was absolutely unbelievable. You want to use something that might cause nightmares? What are you, crazy? You guys are loose guns down there. So we had to go through this whole thing, this whole training thing in giving ketamine. Once we were trained in it, all the attendings, all the residents, we took our exams and whatever else. What was our first use of ketamine in the emergency department? One of my residents had a 2-year-old with a paronychia, decided that his buddy on ortho, he was going to turf it to his buddy on ortho, who came down and then said, well, gee, what should I do to sedate the kid? So his response was, well, we just learned about ketamine, so why don't you use it? And so he disappeared into the room, gave the kid ketamine, was doing the procedure. The kid baby started salivating like crazy. The pulse ox dropped precipitously from 100% to 99%. And he came running out, call anesthesia, call anesthesia. They paralyzed the baby, couldn't intubate the baby, given him succinylcholine, had to bag the baby for 5 minutes, and ultimately this baby was admitted to the peds ICU for a paronychia. So much for our first use of ketamine. So yes, let's use nitrous oxide.
So the desaturation, that's supposedly what anesthesia talks about. If you give high concentrations of nitrous, it all goes into the bloodstream, and then when you stop, it all comes back out and saturates your alveoli, and your sats drop. All you got to do is put them on some oxygen. Yeah.
Well, this one case, I did read specifically, it just didn't work out right. But this is 1 out of 760 some cases, no bad outcome kind of thing. So are we going to go back and stir the pot? We used to use it in the 70s. When I got out of USC, we used to have it there. It was called Nitronox, Entonox. It was a 50-50 bottle. You could not increase its concentration, and they just kind of dropped it. Those of you from England, if anybody notice in England, they have nitrous oxide in the ambulances for pain relief? Yeah, you have it in Canada in the EMS? Is that something new?
No. Oh, our medics use it in Suffolk County.
For those who use it in Australia, do you use it in preference to ketamine for kids? Different?
If your equipment's faulty, you can give 100%. Well, I
You
guess...
can tell that by the patient dying, right?
Doctor in the back? You. Well, last year,
How high a percentage do you use?
Does it have a scavenger on it to remove the nitrous? Oh, because see, that was the issue, is that birth defects in nurse anesthetists exposed to nitrous oxide. So that was one of the reasons that I know everybody's saying, well, now you can't just use this 50-50 nitronox because the stuff's out in the atmosphere and everybody's getting cancer from it. So you need more sophisticated, more expensive equipment if we're going to have it pass through. Yeah, so you have one. Yeah, I'm sure, you know, it's just a hose. It ventilates it. It's not much. Have them inhale the nitrous too?
Alternating back and forth.
The doctor, right. Swap back forth. A little for you, a little for me.
So last year, the same thing came up. Those of you here last year, there was a paper about, it was the same thing. All the Australians, you know, not everybody thought it was fabulous, but a substantial subset. It was one more thing to add to our bag of tricks that we could use that didn't require an IV being started in a kid kind of thing. It was quick on, quick off kind of thing. We still don't have it.
Well,
Pardon me? Dislocated shoulders.
Number 14 has to do with inadequate provision of post-intubation anxiolysis and analgesia in the ED. Of course, my response to this would be, yeah, it's a problem in the ED, get them upstairs to the unit. But nonetheless, this is a chart review, so how can we tell whether or not actually it was inadequate? Well, there's some subtle clues. For instance, you gave no anxiolysis at all, or you gave no pain medicines at all. In fact, the only medicine the patient got was vecuronium and nothing else.
Well, did they appear anxious?
No, they didn't appear anxious, though.
So? What happened to clinical medicine here? You know?
Yeah, it relaxed their muscles. What's the problem here? So, I mean, it's an obvious point, and this is certainly true in our emergency department. It's when the nurse comes and tugs at you. You know, the heart rate's about 180, and the blood pressure's gone up to 240 over 120. Think we could give this guy something to calm him down. But it is true. We have, at least at our place, we do a terrible job of this. And but again, I think the answer is to not board these patients in the emergency department, get them out.
But when you have to, though, you've got to keep in mind, I see a lot of docs that decide, oh, the patient seems agitated, they seem like they're sensing they're on the tube. Go ahead and give them another paralytic. Well, great, you can be paralyzed and awake. That's not a great feeling. So you've got to make sure you sedate them. We talked about Diprovan earlier. That is a great, great drug for this purpose. And if you don't do that, another great drug is droperidol. You can use droperidol for this purpose, and it works fantastic also, and it's very safe to use. But definitely you have to make sure these patients are sedated. You don't want to be awake and on a ventilator.
Diprovan?
What's that?
How are you doing?
Diprovan start at 5 mic per kilo per minute and go up, then just write orders to titrate up to 50 mic per kilo per minute. And somewhere in that range, if the nurses are aggressive with it, within 5 or 10 minutes, you're where you need to be. And there aren't serial doses of boluses given or anything else. It works great. And when you are using that infusion and slowly titrating it up, you're less likely at that point to get hypotensive effects and other problems. And you're not worried about apnea. You want to stop breathing? Fine, we're doing that for you anyway.
All right, 15. Medical emergency teams. How many here from Canada have these mandatory? Aren't these now mandatory in Ottawa? No? Okay, so this is one of many reviews that we've done on this with medical emergency teams, where it's basically if anybody in the hospital says, we're worried about something going on with the patient, the nurse can say it, family can say it, whatever, this team responds to that question, whatever it is, and then they provide whatever it is they need. Many times there's not a physician directly responding on it. It's nurses, respiratory therapy, that kind of thing. And so they put this in place, and this is a before and after study. We'll get into that a little bit. But in any event, after they put this in place, they said they saw about 2.5 calls a day, and they did some follow-ups every day. They said that they had less ICU admissions. They had unanticipated cardiac arrests went down a little bit. ICU admissions went down. They didn't decrease the hospital mortality overall, but they had some sort of jury-rigged standardized mortality ratio, meaning how many should have died and didn't, which looked good. So this is one of the papers that's actually fairly positive for this, saying, you know, they don't go to the ICU as often, maybe our standardized mortality is a little bit better. Things are going a little better with this. This is at odds with a few others that say, you know, yeah, we had less cardiac arrests on the floor, but we sent them to the ICU and then they arrested there. So didn't look all that positive.
How many of you have this in your hospital, a rapid response team?
Wow, this is a big number.
How many of you, now that you have it, raise your hand if you think you'd like to get rid of it? So we have one hand that goes up.
Are you on it?
Yeah, how many of you are on the response team?
Oh, at our hospital, it solves two problems. One is the unrecognized emergency, and the other is I think this is probably not just unique to our institution. The inability to cut through the crap and get the answer that needs to be gotten on what to do with this patient who's not doing very well. You page, people don't respond, they don't come to the bedside. So this gives the nursing staff and the family an opportunity to cut through all that and just say, I'm calling a rapid response. And then a team actually shows up and listens to what's going on.
What was broken that needed to be fixed? I'll tell you, what was broken is the lack of accountability of our medical staff members. I mean, how many times are you called in the middle of the night and you're asked to write admitting orders, or they expect you to do that? They have no intention of seeing the patient until the next day. And if we enable them to do those sort of things, they will be more than happy to stay in bed and not be accountable for the work they should provide and perform for the patient. This is, granted, this works better for the patient, so we should do it, but the reason is people, once they're admitted to somebody, that person's not around a lot of the times, and maybe just a hospitalist program would work well for this too.
You know, what's a fascinating aspect of that is one of the things, the big pushes in medication eras are verbal orders and transcription problems and whatever. So what's going to solve that is CPOE. But one of the unintended consequences that no one's ever thought about is if I'm a physician and I can stay at home and just order stuff on the computer, that allows me to never have to go see the patient and actually see what's going on. So this is actually institutionalizing not responding to a summons for relief.
Well, there are a lot of community hospitals. I work in one where after 4 or 5 or 6 or 7 at night, the only doctor in the building is the ER doctor, and people are just as sick. And this is this idea of the 7-day-a-week, 24-hour-a-day hospital. I don't want to be in our hospital if I'm sick. If I'm really sick, I don't want to be there because there's no doctor there. And, you know, I will get special care. There's no question. They'll come in for me when they wouldn't come in for somebody else. But this is an attempt to address the fact that people are deteriorating around the clock kind of thing, and somebody needs to kind of go see them. So this is fostering the hospitalist movement, where in fact the hospitals are physically in the building, not just on call for some medical groups. And what we've had difficult showing in the literature is objective evidence of sustained benefit in terms of deaths, mortality, really things that you could measure, ICU days, those kinds of things. But we heard that in Canada it was required in the province of Ontario, that these things, and they were spending $1 bajillion to implement this. Any of you from there? And does every hospital have it there? No? So it hasn't happened yet. Because this was over a year ago that this was announced and you were going to spend all this money. I guess you don't have any money to spend anymore on the project. No, nothing. No, nothing. All right, moving on.
And nobody to write down the number of deaths either. So, you know.
All right, number 16, effective 24-hour mandatory versus on-demand critical care specialist presence on quality of care and family and provider satisfaction in the intensive care unit. Basically, Mayo Clinic looked at this from 7P to 7A. Should they just have an intensivist in the ICU? What a novel idea, having them available to actually see sick patients. This is along the same lines. When they put them in the ICU, from a satisfaction standpoint, the families were satisfied either way. There were staff running all over the place. It was one-to-one nursing. It didn't really matter. The staff was more satisfied when the intensivist was available. And also, some of the outcomes were better. So they improved care. They decreased complications. They improved evidence-based approaches to care in the ICU, and those things were improved. Length of stays were decreased, so cost was saved there as well. Some of the things that weren't improved were mortality, readmission rate to the hospital, readmission to the ICU. But overall, again, this is pretty easy. I don't think we need to study this. The physician at the bedside is better than the physician on the phone any day of the week. I'm always amazed, too, as emergency physicians, you're on the phone, you've examined the patient, you've looked at the data, you were right there with the patient, and you feel they need to be admitted or you're recommending some course of action. Somebody who just woke up 2 minutes ago with their fluffy bunny slippers on, 30 miles away says, no, I don't think you're right. I mean, how could they have better medical judgment than you? So I'm glad they studied this, but yeah, put the physician at the bedside and they'll be better every time.
Well, how many of you have that teledoctor kind of thing in the ICUs where the doctors are some other place watching the patients? And is it in your hospital system where you have multiple hospitals? Or
I'm at a community hospital. It's implemented this week.
this week, while you're gone, they decided to throw this thing in there.
And you have the camera up in your room, right?
The camera's a doctor in St. Louis, and I work in North Carolina.
Wow.
And they cover at night with a video system, one-on-one.
Can they speak the same language? I mean, is
Nor-
there a language
not-
barrier there? I'm just wondering.
Yeah, will
So
they be as
this-
good as Radiology Nighthawk? That would be great for the patients if they were. Oh, good for you. Yeah.
So this is a growing trend. Anybody else got this thing where the ICU has got the cameras?
You know, the best solution I ever heard to any of this, or the chair of radiology at University of Wisconsin decided they needed to provide 24-hour radiology coverage. And the way they did that is he bought a villa in Spain. And the radiologists rotate through there, and they sit there 9 to 5 and read films, and then go out and have tapas and sangria the rest of the time. I think that's a nice way to solve a problem.
They said critical care doctors are hard to recruit because they don't want to work at night. So this way they can recruit critical care pulmonologists who won't have to work at night when I and the hospitalist are in the hospital, and the anesthesiologist, because there's only 3 of those 24 hours in my hospital.
Yeah, there is this issue about lack of critical care specialists, that they could never staff all of the emergency ICUs in this country, apparently, with the numbers. Doctor in the back, there was another doctor who's got this TV kind of thing. So there's only 2 hospitals represented in that out of the 80 or 90 here that have it, but it supposedly is a trend.
Well, aren't we seeing the same trend with, I mean, maybe I sound a little negative, but with our medical colleagues, the surgeons now, you know, it is about 5 or 6 o'clock at night. I think this appy would do better in the morning. Let's observe it. I mean, aren't you seeing the same trend? It's 9 o'clock in the morning, fine. Keep them MPO and send them up. I'll fit them in the schedule. But it is amazing.
It's fascinating. There's a revolution that's not happening. If you look at hospitals in 1960, 95% of the patients are elective. They come in during the weekday. Back pains can stay in the hospital for 3 weeks at a time. Most patients are low acuity. You have your hernia repairs and all that sort of stuff in there. And so you run the hospital 9 to 5, Monday through Friday, with a skeleton crew on evenings, nights, and weekends. Now let's fast forward to 2009. What do we have? We have mostly unscheduled admissions. They mostly come in the evenings, afternoons and evenings. They come in flat 7 days a week. And how do we run our business? Monday through Friday, 9 to 5, with a skeleton crew on evenings, nights, and weekends. And we wonder why we have a capacity problem in crowding when we're trying to fit a 7-day-a-week problem into a 5-day-a-week solution. It's really absurd. So and there's actually some great stuff by Berwick and whatnot in Massachusetts that actually shows if you smooth this stuff out, your capacity problems go away. But it requires that we do something besides 9 to 5, Monday through Friday. So it's a revolution that has to happen, that just has not yet happened.
So the next 3 papers are to stir the pot a bit regarding steroids in patients who are really sick, tight glucose control, and goal-directed therapy for sepsis. First one is 17, is about tight glucose control and the fact that this is being applied across the board for all patients in the ICU, independent of what their problem is, based on the fact that in 2001 there was a study that showed a 1/3 decrease in mortality in surgical critical care patients, and so they bolted this thing on to the Surviving Sepsis campaign that was first published in 2004, updated in 2008. Here's a critical look at the use of tight glucose control by these docs at the VA hospital in White River Junction, where they looked at 29 randomized controlled trials involving 8,400 people, comparing tight glucose control and standard care in critically ill adults. Tight glucose control was not associated with any change in the mortality of these cases. They started to tease apart the results to find out, well, is there anybody who got any kind of benefit? What they were able to show is that the incidence of hypoglycemia, 13% versus 2%. And every paper that has looked at this, because we've looked at a number of these 29 papers, basically says we're having trouble showing that this thing that we all embraced is that everybody's doing this, everybody thinks this is cool, turns out to be not so cool as we thought. And so that's 17. 18 is going to talk about steroids and sepsis.
Steroids and sepsis, same thing. I don't know if you know, but I mean, everybody here is subject to the same sort of sepsis initiatives of getting antibiotics within 3 hours and fluids and all that sort of stuff within 6. In the last April or May issue of ASEP News, this had been going on now for about 2 years, all over the world. The total number of patients in the Sepsis Initiative that got all of the whole sepsis bundle in the entire world was 120 patients. That was it. Everybody else didn't get something that they were supposed to.
If you look at Manny Ramirez's data, and we know that it looks like patients do get better with early goal-directed sepsis. But if you dissect things, they threw so many things at the patients, we don't know exactly which one of those really worked. And this is one of the articles that we're seeing now saying maybe, although he said we don't need high-dose steroids, they've been studied for years and it doesn't work. Okay, well, low-dose steroids seem to be reasonable, and that's one of the recommendations. Now they've looked at it and said, well, maybe that's one of the things that really isn't providing a benefit, and how many of these will be taken off the list in the next several months to a few years will be interesting to see.
And they couldn't even find benefit in the subset of cases where they did the cortisol stim tests or measuring your serum cortisol and say, okay, well, only the people who have low levels will get the steroids and that will show benefit in those cases. Didn't work.
It was bad. It was bad for everybody. It was really amazing.
You know, this is one of many concepts in medicine. I have to give Rick credit for a lot of this publishing articles against that. There's things that are just physiologically so plausible. If you look at all kinds of basic science research on glucose control and all the bad things that high glucose does, you just got to come to the conclusion, my God, we ought to get that glucose down and better things would happen.
Wow.
And then when you do it, it doesn't work. Same thing with hydrocortisone. Look, we know you don't respond as well when you're in sepsis and you're not making hydrocortisone and you're critically ill, so we'll just give you a little bit extra. It's got to be such a good idea. Oops.
Well, we think we know better physiologically than the body knows, and that's what sometimes we get proven wrong. Good example is hypertension and stroke. We know that it's actually a transient phenomena. We also know it's neuroprotective to avoid further ischemia in that ischemic penumbra and the area of injury. But what do? Because we think we know better, we try and reduce the blood pressure in ischemic stroke, which is physiologically a bad thing to do. Maybe elevated glucoses in patients who are septic and are critically ill is a response that we should consider not blunting so much.
So 19 is, again, it's one of these before and after studies. This is Carolinas Medical Center, and they looked at their surviving sepsis and septic shock. The other thing about all of these articles is these are patients in septic shock. You know, if you look at the definition of sepsis and you get it at the lowest level, every kid with a sore throat has sepsis. You know, elevated temperature, maybe elevated white count, you can get that. But these are people who are really hypotensive and unresponsive to fluids. That's where it gets into the septic shock stuff. So we've now got this subset of very sick people, and they looked at their before and after. And they said, you know what? Mortality was a little bit better, but it wasn't statistically significantly better. A little bit of a trend, as opposed to the Manny River study, where it was just a phenomenal amount of difference in mortality. The other thing, as I've mentioned, with any time you look at a study, what you got to say is Group A equal to Group B, but for the experimental variable? So are the patients that came in during the time period with sepsis that they studied the same as those who came in the couple of years before that? Well, you could say just on a random basis, probably, but who knows? Maybe there were more immunocompromised people in one or the other. Who knows that they're exactly comparable, which is a fault of a before and after study that you can't overcome. But at least in their study, it said maybe a little bit better. And then again, like has been mentioned already, we don't know which components of this were in fact better. You know, in the Manny Rivers study, they spent 8 hours with these people in person before they sent them up to the ICU. One doc dedicated to them. Maybe that alone is the
That,
part that worked.
interestingly, was not considered an important part of the sepsis study, although they had a dedicated doctor and nurse for that specific patient. That's not important in the sepsis. It's controlling the glucose is what was important. But it's now we got an award at our hospital for a dramatic drop in sepsis mortality over a 2-year period. It went from like 27% to about 13, 14%. So good for us. How did we do that? Several ways we did that. Now, Manny Rivers study, if you look at it, it's 120 patients in each group. Everybody starts with a central line and an A line, and the average starting lactate, the mean starting lactate was 8. And at the end of 6 hours, the mean lactate was 4. And when we first started the Sepsis Initiative, we were including people, as Neal describes, in obvious septic shock. And then we started measuring lactates on everybody. And anybody that had any sort of elevation of lactate and a fever was now called as part of the Sepsis Initiative. So the reason our mortality rate got so much better is we started including
Sore throats.
less and less sick patients. But that's very difficult to control. It's very, very difficult to control for. With pneumonia, for instance, when we're looking, there are very clear definitions of pneumonia that allow you to include or exclude in the measurement. I just got an email today, by the way, that as of the 9th of January, it's a 6-hour measure instead of 4.
Right. Yeah, we discussed that.
Is that true? Okay. And blood cultures are still in?
Blood cultures are still hanging on.
God.
We'll talk
If
about
they
that.
go to
Number
the
20.
ICU, you mean.
Number 20 we'll
Yeah,
talk.
okay.
Yes.
Yeah, well-
But, so I forget where I was.
I don't know, where are you?
So you
Start singing
redefined
again.
your sepsis patients,
we
got
redefined
less
our
sick
sepsis
people, and your
patients,
numbers
yeah.
look good. Okay.
But anyway, in the Sepsis Initiative, the actual definition of who's a septic patient and who's not, because we have to make judgments on all these patients that we review, there's no really good definition. So if we weren't compliant, I'd just say, not sepsis, throw it out.
A couple pearls to throw at you from the Rivers data as well. One of the best indicators of improving sepsis and resolving sepsis in response to therapy is actually resolving elevated lactate or normalizing lactate. So keep that in mind. And also, don't take the shortcut saying, I'm not going to order the lactate. It's a special tube. We forgot to draw it properly. I'm just going to look at the CO2 on the basic metabolic panel. The lactate will rise before the CO2 will fall. So you will miss cases if you're doing it that way. So order the lactate.
Although
one of the things that you never see in any of these studies where they measure mortality is withdrawal of care. How many, I mean, in my hospital, we have some real sick elderly nursing home patients, and we recognize they're septic, and after a long talk with the family, they say, let grandma go. You know, she hasn't spoken in years, she doesn't move on her own, and she never wanted to be intubated, and thanks for your help, but withdrawal of care. And I never see that in this. Maybe they never let these people go. I don't know.
Well, isn't it one of the issues for the ER docs putting in these, having these special catheters put into your heart to measure the central venous whatever?
You mean the
The
one
central venous-
manufactured by Manny Rivers?
Yeah,
The
that
central
one.
venous
That catheter?
Because when you think about it, you're just basically going to give fluids to somebody who has sepsis. You're going to give them antibiotics. The data on steroids and is not so good, and the data on tight control glucose is not so good. Pressors, we have a paper that says it doesn't really matter what pressor you use. It doesn't matter at all. You can pick this one, that one. They're all about the same. So the fact is, what is unique for this whole endeavor now? What makes it so special? It was this catheter kind of thing and this lactate business. But the fact is, you're going to treat it anyway, and maybe we won't have something exacting. But the question is, could we just get back to what we were doing before and get similar kind of results as we're disassembling each one of these items one by one?
They wanted us to do these measurements at our institution. I pulled Manny's paper, and there's almost a linear relationship between the central venous O2 sat and the lactate. So if you have a very high lactate, we just recheck it a couple hours later to make sure we're going in the right direction.
How many here do ultrasound in their ED themselves? Because I just went to a course, I don't know, I guess in October, where what they do is they look at the inferior vena cava, and they say if it's flat, they need fluids. And if it's already full, they need pressors. And I don't know how skilled that is, because I don't do that, but that sounds like the substitute for an invasive procedure. You know, every other study that so far has looked at putting in central lines and pulmonary capillary wedge pressures shows increased mortality from it. So why in this one should that be the component that decreases it?
You know, Rick brings up a good point, too, that are any of these concepts really new? No, but are we really just focusing on it now? Now that we're focusing on it and we're spending time really addressing early management of sepsis, are people going to get better? Yeah, because now it's an initiative and now we've got our teams focused on doing this the right way. But were we really doing it wrong before, or were we really just not paying attention to this class of patients we were missing?
Oh, I think we were doing it wrong before. There's no question in my mind we were. On the pneumonia thing, everybody debates 4 hours versus 5 hours, but if you looked at your pneumonia cases before all this pneumonia initiative happened, a lot of places and a lot of patients didn't get their first dose of antibiotic until they were admitted to the floor, and which meant they may have been, you thought they were sick enough to go in the hospital, but they got their first dose of antibiotics 18 hours after they arrived because it was given on the floor. So I don't think the real difference is 4 or 5 hours. The real difference is 4 versus 12 hours. All of us in the room believe that there's a moment at which it's too late, that the battle between you and your bacteria is now lost. So you'd like to give antibiotics before that time. Our tendency has been historically to work people up, get the best answer we can, and then treat. And so, at least at my institution, there's been a profound change in that when you see somebody that's obviously critically ill with an infection, they get the antibiotics right then and there. It doesn't matter what the results are of anything. They're going to get it before the results come back. So I think there is a very substantial system-wide difference in the way.
Well, I think on the way we approach them, but is it a new concept that sepsis does better with early antibiotics? No. Is fluid resuscitation important in improving cellular oxygenation delivery? Is that new? No. A lot of this isn't new, but now that we're focusing on it, we're doing it better. But the design is different now. We're focusing on the process.
But also by ordering lactates.
Yeah, that's a difference. You're right.
The difference to me in ordering lactates is every now and then you find patients that looking across the room, they look great, but their lactate is 6 or 7, and by God, they crash in the next hour and a half, and that it's valuable knowing that.
Yeah,
lactate.
early detection.
I think the other thing that it did was when you look at the amount of fluids that these folks get, this makes most internists shiver. I mean, you know, trauma surgeons would give this kind of stuff without thinking twice, but this is bigger doses of fluids than your average internist would give. So I think we've focused on, now they're on this protocol. Oh my God, I haven't given them another bolus of huge amounts of fluid. So maybe that does it.
Number 20.
20. Presence of pneumococcal bacteremia. Does it influence clinical outcomes in patients with community-acquired pneumonia? Do we need yet another article to tell the joint that we don't need to do blood cultures for pneumonia? Well, if we do, here is another one, and maybe they'll listen to this. I mean, they identify in this article that you're not even going to get those culture results until a couple days, maybe 3 days later into the admission. And despite the fact that the patients are looking better clinically, oftentimes that delays de-escalation of care. So we're not going to change them from IV antibiotics to oral antibiotics. We're not going to move them out of the ICU. We're not going to get them home quicker just because this comes back positive. And the great thing about this article, it looked at outcomes, and despite them being positive in a lot of cases, these patients were doing just fine. They had already been treated for 2 or 3 days effectively, and antibiotics were chosen almost routinely, appropriately at the time of admission, so it just was a non-issue. So why order the test at all?
We had some great papers that looked at pyelonephritis and whether the outcomes were different if you had bacteremia associated with pyelo or you didn't. And it was just like this. Absolutely no, it didn't matter whether you had bugs in your bloodstream or not. You didn't give more antibiotic. They weren't sicker longer. There was no difference. And this paper says there's no difference.
I think there's a difference of about $15,000 in payment to the hospital.
There's your difference.
Well, if you can name the causative agent in terms of Medicare payments in this country, I don't know if that's still operant. It's a shame if it is. But anyway, this is a great paper to kind of shine the searchlight of scientific inquiry on some of this knee-jerk stuff that we're being asked to do, which discredits the effort. If you come up with criteria which can be shot down so easily, it discredits this effort that people are, fundamentally in favor of better care. But you got to pick up better criteria. Antibiotics for this is a great paper for 21. Is that where we are? Yes. This is kind of interesting. This is not necessarily, it is, they say it's a meta-analysis. 9 placebo-controlled randomized trials of sinusitis, clinically diagnosed, the same way you would diagnose it if somebody came into you. This is 2,500 cases where they took the data from the individual cases and made one huge mega study involving 2,500 cases. And they asked the question, well, what difference does antibiotics make? And the answer was the number needed to treat with antibiotics to achieve an earlier cure. Didn't mean that it was not going to get cured. This is going to be a little earlier. It was 15 patients. 15 patients have to be treated by antibiotics to get you better a little bit faster. All of them are equally subject to the likelihood of diarrhea occurring or rashes or whatever. They couldn't find a subset of people who were particularly high yield in terms of the length of your sickness, the severity of your symptoms. It didn't seem to matter. 1 in 15 got better a little bit faster, and there was no way to tease out who are the ones who are going to more likely get the benefit or not. This is I think, one of the most powerful studies on this topic. It's published in The Lancet. You're not going to find a better journal than that. And it is consistent with a lot of other studies that the number needed to treat on something that's so obvious that everybody would treat is high. And so I think one of the take-home messages here is, Mr. So-and-so, I think you got some sinusitis here. Here is your amoxicillin, your Z-Pak, your Augmentin, whatever you want kind of thing. But you should know that the majority of the people who get this don't really get much benefit from it. Don't think that this is a miracle. Don't think you'll be better in 2 or 3 days, because the fact of the matter is that the small minority of patients who get this will get better a little bit sooner, so that you set up their expectation about this rather than, oh, I need it, I know I need it kind of thing, when in fact, these are the numbers, compelling numbers, 2,500 cases.
I'd agree with everything Rick said, except the part where we're going to give them the antibiotic anyway.
Yeah.
The tough thing
Did
is...
I say that?
You kind of
No,
did.
I said that that's what we're...
All right, that's... And this is the time where it's tough for us. I mean, you've got to sit down at the bedside and explain to people why this is a bad idea, and maybe just letting them know, when you really need the antibiotic, if we're increasing resistance, you're not going to have the benefit of that antibiotic when you need it. 99% of these cases are viral. It's not beneficial to you. Well, I used it last year, and I get better every year when I get this. It's coincidental. When you walked outside, the sun rose as well. It doesn't mean the sun, got your rhinosinusitis better either. It's totally coincidental. And you just have to educate people so we stop prescribing antibiotics unnecessarily.
The rap I give is I just give them the history of sinusitis. Years ago, 30 years ago, how'd you diagnose it? Painful unilateral sinusitis and a high fever. That was bacterial sinusitis. And then people started doing imaging in emergency departments, a Waters view. And if there was fluid there, oh my God, that's sinusitis, they need antibiotics. And then we started doing CAT scans. Oh my God, there's fluid there, we need to do sinusitis. Then there was a wonderful study in the New England Journal where somebody convinced a whole bunch of people with colds to get CAT scans and showed that 100% of them had fluid-filled sinuses. And that was the definitive final nail in the coffin that this has nothing to do with anything at all. I have been 100% of the time been successful in convincing my patients that you always get your sinuses filled when you have a cold. That's a virus. Now, if one of your sinuses starts to really act up and it gets red and swollen, painful, and your temperature goes up as high as 106 and you're confused in a coma, that's bacterial sinusitis, and you need to come back and we'll treat you. But that this other thing is a cold. Oh, by the way, do you smoke? Oh, my God. I tell you, not only as a doctor but ex-smoker, this won't go away for a month if you don't quit smoking.
Although
Nice work. Yeah.
I honestly don't think that you need to necessarily go the next step and not prescribe it. But if you set up the expectation that this is not going to make you a lot better, and go through some of these in terms of 1 out of 15 people will get a little bit better if we take this stuff, I think that has accomplished something, even if you elect to prescribe whatever you're going to prescribe.
See, the trouble with this, I actually agree with all of what's been said. The trouble is that the occasional rare patient with sinusitis gets a terrible, terrible, terrible complication. And they get meningitis, they get cavernous sinus thrombosis, they get brain abscesses. And so those are not usually in the mix of these randomized clinical trials kind of thing, because it's clinically diagnosed sinusitis. It's like clinically diagnosed otitis media. Most people don't have it. So when you diagnose sinusitis clinically, you just say, oh, you've got congestion and snot coming out of your nose. That's the clinical diagnosis. Well, most of those people don't have it. So they've taken the low risk, the low yield people and said it doesn't make a whole lot of difference, and that's probably true. But things like isolated sphenoids and sinusitis, if you see that on a CAT scan, that ought to get your attention.
Yeah.
Sometimes unilateral frontal sinusitis, which is not the usual place for it, those people can get bad. So if you're not going to treat under some of those circumstances, and I think it's most of the time reasonable to, just remember that this is a disease that has the rare, real bad outcome.
And diabetes makes it very tricky.
Sure.
But because they get this weird
Mucormycosis, yeah,
mycosis
yeah.
Going.
But don't think also that if you prescribe those antibiotics, you're absolutely going to prevent those complications. Those people are probably going to get them anyway.
Actually,
you know what,
that's great. I'm reviewing a case right now of sinusitis, got Ketec, whatever that thing is, that antibiotic that kills you or something like that.
Everything but you.
And the 20-some-year-older called back the next day. My eye is swollen, kind of thing. They said, keep taking the medicines. And on the third day, he had a what's that infection in the back of your eye called?
Retroorbital.
Retroorbital, which then moved onto a cavernous sinus thrombosis, and he was on the world's most aggressive antibiotic. And so,
I don't find most of these conversations to be really that lengthy. If I see somebody with an upper respiratory infection, I don't say, oh, it's just a virus. I will say explicitly, you know, if you have a sore throat, we worry it's strep. If you have a cough or something like that, we would worry it's pneumonia and you need antibiotics. But when you have a runny nose and a sore throat and a cough, the only thing that will do that is a virus. There's no bacteria that will do that. And okay, thanks, Doc. See you.
I think it's helpful to direct your conversation with your patients about what you know the obvious expectation is going to be. They're not going to question you and ask you. Most of them won't say, well, what about the antibiotic? But it's in the back of their mind. They came in, most of them, looking for the antibiotic because that's what they think will make them better. You just have to re-educate them. One other comment real quickly, too, is how many of us are working up somebody with a headache and we find the incidental sinusitis or chronic sinusitis that the radiologist reports. Are you starting antibiotics? Don't do it.
last year we had this course during the Super Bowl game, just like we did this year, kind of, and the Canadian commercials are not the ones necessarily that you see in the States. And the Canadian commercial that I thought was the best in the Super Bowl was the one sponsored by the the Canadian Academy of Family Physicians and the Pharmacists Association, and it was about not all bugs need drugs.
Right.
This Canadian commercial, well done, 30-second commercial, trying to make it clear that this is a national.
What was funny about it? Even a 5-year-old knew. I just have a cold and I don't need antibiotics. It's hilarious. If you just played that for adults in the U.S., I think, well, if the 5-year-old gets it, I guess I don't need antibiotics either.
Now, 22 is I think, shows something entirely different than what it shows. It compares penicillin, amoxicillin, and cephalosporins in the treatment of strep throat and the failure rates. And let's, rather than debate whether or not it's important, these failure rates or not, I think the important study for all antibiotic treatments is anytime you compare a four time a day to a 2 time a day to a 1 time a day drug, the 1 time a day drug should win 100% of the time. And of course for strep throat, a 1 time only drug should win 100% of the time. So IM, penicillin, or ceftriaxone, or chloramphenicol, or something that starts with a Z, not Zithromax, but something that's really serious. Zygris. How many people give Zygris for sore throat? That's nice. Good. Anyway, this showed that cephalosporins did better than penicillin or amoxicillin, but I think it has more to do with how many times a day you have to take a drug than the specific drug itself.
I actually don't think so. I think this has been shown in lots of other studies that it's not so much that the strep is not sensitive to the penicillin, is that there's commensals floating around the throat that do take out that are penicillinase positive, and they take that out of the picture. So this has been shown many, many times that recurrence rates are higher when you don't give a cephalosporin and you do give a penicillin drug. And then the studies that show effectiveness of penicillin drugs basically show it doesn't matter whether you give them 4 times or 2 times a day. So I agree. I like drugs that go less frequently, but with the penicillins, if they're taking sort of any of it a couple times a day, they'll get the same effect.
Before we move off to another version of the antibiotic thing, which is 23, we had a great paper that you may find helpful. It says never tell a patient they have bronchitis. Never tell a patient they have bronchitis, because the expectation bronchitis is antibiotics. Swap that out for you have a chest cold. Oh, It's only a chest cold? I'm glad, doctor. I thought it was...
Thank God it's not that bronchitis I had
Yeah,
last year
right.
that I coughed for a month with that.
So you just swap out those two terms, and you have to tell them that this cough is going to last at least 3 weeks. If you give them the expectation they're going to be better 3, 4, 5 days, they're going to be knocking on your door again. I'm not better, doctor. This is a 3-week infection. That's what the expectation should be, and you got a bad chest cold.
Well, I'm going to disagree a little bit. I think there's some good trials that have shown if you compare placebo to bronchodilators or antibiotics to bronchodilators for people who have a cough with a cold but who do not apparently have reactive airway findings on exam, that they feel better quicker if they're given the bronchodilator. I can't see any downside to it. And it's my version of the antibiotic. Oh yes, we used to have to give antibiotics for this, but now we have this new drug that's much better. And do you smoke?
Or you would say, some of those old-fashioned doctors who haven't read the journal the last 30 years still give antibiotics. So you basically, that's the preemptive strike, as Neal would say, to make it...
And you even willing to give it a little neb in the emergency department. They feel shaky and jittery, so that you know, it's a positive effect.
Although, you
Tell
know...
them it opens up their lungs and all the infection can come out that way. You don't need antibiotics for that.
And that's why I'm wearing eye protection while I talk to you.
Although, you know, and that was good. That was going to be the swap out. You were going to give a MDI with albuterol in terms of the antibiotics. But more recent papers have looked at what is the subset of people who really get better. The subset of people who get relief from this thing, they do have some evidence of reactive airway disease. So it would be nice if you heard a wheeze. And if you heard a little wheeze, then they'll get some benefit.
Well, you can pick out the exact patient that will respond. And they come in with the following complaint. I've had this cough for 3 weeks. My doctor first tried Zithromax, and then he tried Levaquin, and then he tried, triple IV antibiotics, and I'm still coughing. Oh, well, let me give you this little thing right here, and poof, they feel much better.
This post-bronchitic syndrome, actually a friend of mine's a pulmonologist. He says it's the most common diagnosis he makes. People come in 4 weeks, they've been coughing forever after a apparent chest cold, and nobody's tumbled to the idea that this is just persistent inflammation without actual infection. And almost all of them, he says, their other chief complaint is they've had so much diarrhea from all the courses of antibiotics that they've been given.
Well, you got to think about, too, if you're 3 weeks or beyond, you've got to think about the possibility of pertussis. Just put that in the back of your mind and consider
Think about
that.
it, but what do you do about it? Nothing much. By the time you're coughing that long with pertussis, there's nothing you can do for it. But the other thing I think is a question I'd be interested to see what other people do is whether, besides bronchodilators, if you put these people on steroids for a while, they cough for a month after stuff. How many here actually add steroids to that?
Yeah, we're
mix?
all friends. You can tell us.
Yeah, yeah.
You know, we're all...
I think it's reasonable in some people to do that the bronchodilators may not be enough. What I tend to do is give them the prescription for the steroids and say if after 3 or 4 days just the bronchodilators haven't done it, then go on the steroids for a while.
Sure. If you do treat the pertussis end of things, you stop shedding, and also, as a very close second in that subset of patients with cough 21 days or beyond, is chlamydial pneumoniae being the possibility. So if they weren't treated with a macrolide or fluoroquinolone, they may not have been adequately treated.
Question? Inhaled or oral? I just give them oral steroids, yeah, for that. But so 23. So risk of major bleeding during concomitant use of antibiotic drugs and warfarin. So this was looking at bleeding episodes and whether they were on any antibiotic of any kind, and what do you think they found? A lot of times, if you put people on an antibiotic and they're on warfarin, they get bleeding episodes. Flash. I don't think that we should even restrict this. So they say, be careful. You know, if you're going to put them on antibiotics, be careful about measuring their INR. Any medication that you're going to change, anytime you tell them to eat, less or more green vegetables. I mean, the management of warfarin is really significantly tough. I mean, they go through all kinds of how many doses of spinach did you have today and all that kind of stuff because everything influences it. So I think the take-home message is, sure, antibiotics do it. Some do it more than others. There are very few that don't do it. But I think you just got to tell people, get your INR rechecked.
Skin abscesses.
Where is that?
Oh, here we go, number 24. Yeah, talking about basically skin abscesses, and this study actually looked at those that were predominantly from MRSA. They had a bunch that were, 88% of them. They said, well, were they better with IND? Did cephalexin work well or no antibiotics at all? Well, they said, well, cephalexin was, didn't work much, any better than not having an antibiotic. And the key is, first of all, cephalexin is not appropriate for MRSA anyway. It's just not sensitive. And the other issue is, it's a take-home message for us all, that a classic abscess presentation, whether it's caused by MRSA or not, the overwhelming majority will get better like other abscesses do with IND alone. Do they need follow-up? Yes, you've got to make sure that you provide that now. And if it doesn't get better, you've got to look into other things. But most of these are going to get better with IND.
How many culture them when they get an abscess? And the reason then being, would you then put them on something for, if it's MRSA? So you always treat with it, just an abscess with an IND and not with just cellulitis or something like that?
Well, one question is if you don't treat, would you like to have cultured if they return 2 days later and get worse? So it'd be nice to have that information.
On the other hand, you now label them MRSA positive. What happens then when patients come in with a sprained ankle and they've got this MRSA stuff, and we run in with the flamethrowers in the rooms and all that kind of stuff.
Not in the emergency department. You can cohort them. It's fine. It's only on the inpatient units that they have to. You got to have an armed guard.
Although the problem is with the culturing business, in our hospital, that's going to be a couple $100 for a handful of Bactrim. Yeah, it is very expensive in the States to do cultures. Actually, I look at the literature on this thing, and I think that that's more myth than not. I've looked at stuff since 1977 when we started this, and if I saw a paper that said packing versus no packing on the kind of abscess we see, I'd put that in our database in a heartbeat. But I think we just have this tradition of putting rags in these things to act like a cargo net for the bacteria and white cells to come out of that thing.
I think what we do is they have a localized collection of pus that can't get out, so we open it up, and then we make it so the pus can't get out.
Let's stuff it in real tight.
I think it came from old surgical stuff where you packed abdominal wounds that had either opened on their own or you never closed because you were worried about infection. And so your job as the intern was to go in every day and change the packing and let it gradually kind of heal up so it couldn't seal over again. And we translated that to simple cutaneous abscess where we put this stuff in and then people take it out and then they put it back in again.
Later to change it to
right,
a clean
that
pack?
feels good.
Hey.
Yeah. So actually, I read a recent interesting article where you just make a cut on both sides of the abscess, drain it through that, and then stick a rubber drain through it, tie the drain so that they can shower, they can do all this kind of stuff, and a week later pull it out, like we do with labial abscesses, where you just have those little ward catheters in them.
I for years now I put in the packing and then either had them come take it out or then come back and we'll take it out a couple days later, and then that's it. We're actually doing a randomized study now of INDing with packing versus INDing and then closing. And
Actually,
there is a British study on
don't bother
that.
doing it. It's already been done.
Yeah, the British study's been done on that where they
Saving you
carotid
the
out
trouble.
the abscess and then they sutured it closed.
Do you imagine those nutty Brits?
And they did fine.
and the outcome was just fine.
Right?
To tell the truth, potential liability for concealing physician impairment. This was actually a great case. This is about an anesthesiologist who became a drug user and was taking narcotics and those kinds of things and squirreling them away from other patients. Ultimately was fired by his group of anesthesiology colleagues. But a couple of guys felt bad about this, and so they wrote letters of recommendation when another hospital was about to hire this anesthesiologist, and never said anything about why he was fired or anything like that. This anesthesiologist at the other hospital, under the influence of drugs, has a big anesthesia accident. Somebody has major brain damage and a multi-bajillion-dollar lawsuit, and the hospital subsequently finds that this guy was actually on drugs at the other hospital. They sue, the hospital sues the anesthesiology group that had hired them prior, and these individual doctors who wrote positive recommendations regarding their colleague to give them a break. And the point of this paper is you have an obligation not to potentially have patients hurt by the behavior of your colleagues. Do not, through inaction, allow harm to occur. This case basically says it's really tempting to not tell people very much about why somebody's fired. And I'm sure,
But part of the argument is you'll get sued if you do.
right, and I'm sure you have a lot of ways to deal with this because you've got 500 doctors.
Yeah, absolutely. I would say as far as the drug issue is concerned, most state legislatures and state medical boards have provisions to help people help providers who are impaired. And they also have reporting requirements. If you identify somebody who is impaired, you have to take them out of the line of duty right now. So if you're their employee or you're their partner and you're aware of this and you do not act upon it, then you're culpable. And that's where the issue is with this case, that then they didn't report it, they went ahead and got them to leave or whatever, and they showed up somewhere else, and then the patient is injured. You were culpable if you didn't intervene and comply with the state regulation or statute that said you should have reported and gotten them some help. I mean, if you recognize somebody's having a problem, you got to take them offline and have them drop urine right now. It has to happen. And from an employment standpoint, oftentimes they have to be taken out of work and sent through a re-entry program. They get a new contract. Here's what you have to do. You have to do X, Y, and Z. You've got to go through this detox program, and then we'll bring you back with a different contract. And if they won't comply with those things, they don't get to come back as an employee.
But then again, what about these letters where people are very reluctant to put anything in them that would be viewed as...
We picked this up at a conference a number of years ago, and the dean's office does this, and we do this in our office too, is that anyone that requests a recommendation, we have them sign a waiver, and it details that, things that may be said in your recommendation that you may view as negative, et cetera, and so forth, and you're agreeing to let us write the recommendation. And what that allows is for negative recommendations, if they refuse to sign the waiver, then the requester of the recommendation, all we do is write them a letter saying, we'll be happy to send you a recommendation as soon as the client signs a waiver as to what we're going to include in the content of the recommendation. That's all they need to see.
Well, the waiver is interesting and it helps you, but it doesn't completely isolate you. And there are certain rights that you have that just can't be waived. And even though you have a form, you can say, sign this and you're waiving certain rights. If you're negligent in your behavior, you can ask somebody to sign away whatever you want, and it is not enforceable. So you have to be careful with that. Our group has gone to the extent of, I think it was probably about 8 years ago now, we do non-valuative references. I got one the other day for one of our docs that's leaving and going somewhere else. And we turn it over to the legal department, and they provide a couple things. Yes, they worked for us, and here were the dates of employment. Thank you very much for the inquiry.
And they were not arrested, to our knowledge, during that time.
That's it. I mean, that is it, because anything else you provide that's of some sort of value, they were a great person, or they weren't a great person, or this or that, trust me, it will come back with an issue for wrongful termination and or inability to get gainful employment elsewhere, and it's not worth the risk.
To sit or not to sit?
To sit or not to
Sit. Definitely sit.
Yes.
All right, moving on.
I think the big concern is not to sit or not to sit, but whether you actually look at the patient while you're typing at the computer terminal or not. Our new way of providing care to patients.
We had a great case where we measure patient satisfaction with 100% of our physicians, 100% of our visits. And we had one site several years ago that just was not doing well with Press-Ganey scores. But there was one shining star in this department, and the doc was doing great. And so our chief medical officer went down to the site and, what's that?
He was paraplegic?
No. No, but it's interesting though. Went down to see what this particular doc was doing differently, and the doc did sit down, but the doc had some sort of tic, so every time he talked to the patient, he just kind of nodded all the time. And it was great, it worked great for him. So we got the other docs to do it, it worked out fine. But the key is, undivided attention. Patients know they have to wait, and they know you're not going to stay a long time. But if you're spending 30 minutes trying to get out of the room versus 5 minutes really focused on their problem, the 5 minutes of focused attention is really all they're after. And I think sitting down really shows that you're not trying to get away from them.
It's often been said, if you're going to have a head tremor, have a yes head tremor.
Oh, yeah.
Not a no head tremor.
Yeah, that's good.
You don't get along
Depends
with
on what social context we're really talking about.
Will mandated minimum nurse ratio, staff nurse ratios, lead to better outcomes? So this is a California paper where they have minimum-based things, and of course it's studied by the University of Pennsylvania. Not sure how that came about. But they look at a couple of outcomes of interest: 30-day acute MI mortality, mortality among surgical patients with specific post-op complications, and they said, you know what? you have a little decrease in the MI deaths with better ratios, but when they had a fairly good ratio already, bumping it up a little more didn't help much. So it was a little bit of help in a few selected things.
Yeah, we have a real tough time in California. Any other California doctors here? We have this mandatory staffing ratio that says for every bed that we have in the emergency department, we need to have one nurse for every 4 beds, one nurse for every 4, and you have to have a special dedicated triage nurse. And it doesn't matter whether you have any patients in those beds. So at 4 o'clock in the morning, we have the same number of nurses as we have in 4 o'clock in the afternoon because the state of California knows how to staff hospitals. Obviously, this was a move by the nursing association to make sure that staffing didn't get really bad, but the unintended consequences were pretty serious.
This is an area that's just a big black hole. There's no really compelling evidence for any particular given number. We knew in our own department that we had extreme shortages in staffing as defined by the nurse is absolutely busy, can't take a lunch break, and patients are still waiting an hour, hour and a half for nursing to do nursing tasks. I mean, so it just sort of passes a sniff test. You don't have enough nurses. So we undertook looking at what the nurse staffing things were out there. There was Emergency Nursing Association, there was California, New York State, there was 2.5 patient hours, a nurse per 2.5 patient hours per patient, and there was a 5th standard. I don't remember what it was, but based on those 5 standards, we needed between 69 and 128 nurses for the emergency department. The ICU staffing of 1 nurse per 2 patients, the floor staffing of whatever the ratios are there, all this stuff's just made up. There's no real good science to it. That's not to say that if we did, that the staffing would be less. It may be that the staffing is much more. A huge problem for the emergency department is you can't define the staffing until you define the task. If our task is to see the patient sometime before they die, or see most patients sometime before they die, we can staff it with 1 nurse and 1 doctor. And historically, our staffing patterns for the emergency department answer the question, how little resources can we get away with without killing somebody today? But really, our task has been redefined. You got to get an EKG within 10 minutes. You got to get a CAT scan on a stroke patient within 20 minutes. All this other stuff, if we're going to meet those goals, should really drive what our staffing looks like. But there's just no science to this right now. It's all witchcraft.
Let's just skip 29. That's pretty obvious.
Let's skip 30.
Well, 30 is the best, but one of the best studies in the
Well, 30.
chapter.
Let me tell you the study, and then you guess the result. We've got this trauma system. We've got people going out there picking up traumas and bringing them to hospitals. What do you think the outcome is if you just have BLS versus ALS in trauma patients? This group thinks they'll be the same.
This is major pain in the butt for all of the people who think that paramedics matter. This OPO study was really compelling, well done, very comprehensive, before and after. We have EMTs before, paramedics after, no difference. Now, there may be some kind of loopholes in here.
Well, what we talked about before is stay and play is a bad idea. I mean, if you're going to stay and increase the time on the scene to get these ALS interventions done, it's a bad thing. But what they didn't specifically look at from my review of this is what if they didn't stay and you measured that once being performed en route? Is there benefit to ALS? So we don't want to send the message that there's no benefit to ALS at all, but it's not worth staying on the scene longer for, that's for sure.
There is a question of external validity also. I couldn't conclude anything from this for my area. Suffolk County is large travel distances to the hospital. So whether or not paramedics or BLS people make a difference when you're just a few minutes from a hospital is very different than if you've got a half-hour, 45-minute ride.
Okay.